Okay, everybody, a warm welcome at this ERKNet ESPN seminar or webinar on Lowe disease this afternoon. The webinar will be presented by Tina Verschuere and Arend Bökenkamp. My name is Tom Nijnhuis. I'm an adult nephrologist from the Radboud UMC Nijmegen in the Netherlands, and I will be your moderator today. First thing that I want to do is to introduce our speakers of the day. Arend Bökenkamp is one of the two speakers today. Arend Bökenkamp is a pediatric nephrologist that received his medical training at the Medizinische Hochschule in Hanover, in Germany, and worked there as a pediatric nephrologist, after which he worked as a consultant pediatric nephrologist in Bonn, and then made the move to the Netherlands, to Amsterdam, where he has since been working at the Free University Hospital there, which is now part of the Amsterdam University Medical Center. His clinical work actually covers the entire spectrum of pediatric nephrology, but he has also a specific interest in renal tubular disease, in particular Lowe syndrome and dense disease. And he also was one of the chairs of the ERKNet Metabolic and Stone Disease Guideline Committee on dense disease, which is of course a disease closely related to Lowe's disease. He is also an ESPN Council member, so it makes perfect sense that Arend is to present his webinar on Lowe's disease here today, which he will do together with our ePAG patient representative, Tina Verschuere. And Tina Verschuere will speak about her experience with the disease. She and her husband have 2 children and 1 foster child, and their son has been diagnosed with Lowe syndrome. And she's a patient representative for Lowe syndrome, and in 2023 became an active ePAG representative within ERKNet. And as I understand, Tina will go with her presentation first, and then Arend will follow. But before I give Tina the floor, I would like to ask all of you to ask your questions in the question box, which you see, at least in my view, on the right side of your screen. So that we can also try to have a lively discussion afterwards. Okay, Tina, the floor is yours.
Thank you. Hi, I'm Tina, mother of Caetano Callens. Caetano is born at 14 weeks after a normal pregnancy. We noticed at the beginning that he had less motoric development, so physiotherapy was started when he was 14 weeks. We saw a slow evolution of his motoric skills. It was not enough, so neurological evaluation in his 2nd year of life showed persistent hypotonia and weak peripheral reflexes. He had no notable facial dysmorphisms except a relative macrocephaly. You can see my son in the picture also. At the age of 2 years, the facial features of the proband started to evolve, with coarsening of the face with a prominent nasal bridge and a short bulbous tip of the nose. Mild tapering of the fingers was also noted. When he was 2 years and a half, mild thrombopenia was observed. And also dental evaluation showed dental hypoplasia and hypomineralization. The growth retardation continued to increase, and radiographs showed the delayed bone age, a poor mineralization of bone, and typical signs of rickets at the level of the metaphysis. And you can see also at the pictures what I said. Blood tests showed metabolic acidosis and profound hypophosphatemia. Urania analysis revealed proximal tubular dysfunction with renal phosphate wasting and low molecular weight proteinuria. From the age of 3 years, a vision disturbance was observed. Ophthalmological evaluation revealed a bilateral nuclear cataract and hyperopia. So, wait, I cannot see it. Caetano was presented with neonatal hypotonia. Further investigation for growth disturbance revealed proximal tubular dysfunction. At the age of 3 years, Caetano developed bilateral cataract. The clinical suspicion of the diagnosis of Lowe syndrome was genetically confirmed. So, this was our path to diagnosis of Caetano, knowing this was just the beginning. I have learned it was said that a child's first 3 years are the most important, laying a foundation for the rest of their lives. For us, this meant a lot of research for Caetano, a lot of uncertainties, sadness, hope. Today, Caetano's life looked like this. He takes medication supplements. He takes medication supplements 7 times a day, a growth hormone injection every day, consultation every 6 to 8 weeks to the Ghent University Hospital. He takes classes in special education, frustrations about things that doesn't work out almost daily, and difficulty to deal with emotions. You can see here the evolution of the growth injection. I hope you can see, but for Caetano, it works with the injection to grow faster. I cannot see my lines, excuse me. For us, as in recent years, we have all been looking for our way. My husband and I were looking for a way to communicate about the fact that Caetano's future is so uncertain. My daughter was looking for a way to find her place, since Caetano takes up a lot of space within the family. Today, I can say we have found a nice balance. We go through life positively and try not to think about the future. It's about today. We know that Caetano doesn't fully realize it yet, but right now we are carrying the biggest burden for him. It certainly hurts knowing that he will have to wear this one day. We as parents feel like we can never relax. Think about giving medication every time, explaining the difficulties he feels, trying to calm him down when the frustrations he expresses. It takes a lot of energy from the entire family to care for him. It has taught us to be happy with the smallest things in life. And he also taught us to love deeply because the bond you build together is so real. But we are grateful for today and we will see what tomorrow brings. Arend?
Okay, so I'll take over and we'll have a look. Can everybody see my screen? Yes? Okay, yes, my name is Arend Bökenkamp. I'm a pediatric nephrologist in Amsterdam in the Netherlands. And Tina, okay, now you can see my screen. Yes, my name is Arend Bökenkamp, pediatric nephrologist in Amsterdam in the Netherlands. Tina, thank you very much for giving the introduction of your son, who has many of the typical features of Lowe syndrome, which I will try to put into perspective today. Yes, and I have no disclosures. Ocular cerebrorenal syndrome of Lowe was first described in 1952 by Lowe. It's inherited X-linked and due to a mutation in OCR1 gene. About 30% of the cases are de novo mutations, about 3% mosaicisms, and in some 10% no mutation can be demonstrated. It is a very rare disease. The prevalence is about 1 in 500,000 in Italy, and in Poland they found 1 in about 2 million inhabitants. So it is a very rare disease, and many of you maybe haven't ever seen a patient with Lowe syndrome. The basis of the disease is a defect in the phosphatidylinositol 4,5 bisphosphate 5 phosphatase. Well, this is the most difficult part of my presentation, spelling this word. I'll explain to you later what this means. Well, the key manifestations, they are oculocerebrorenal. So the key manifestations involve the eyes with congenital cataract and glaucoma, the central nervous system with the congenital hypotonia and the absence of tendon reflexes you've just heard from Caetano, severe intellectual disability, but still about 25% of the patients have an IQ above 70. About half of the patients have seizures and behavioral abnormalities. I will come back to that later. This is very typical of Lowe syndrome. As pediatric nephrologists, it's the generalized proximal tubular dysfunction, the incomplete Fanconi syndrome, which stands in the center of our manifestations. And unfortunately, we see progressive kidney failure. Well, there are also other manifestations of the disease, and this is one of the classical things, is short stature, which starts in infancy. So at birth, the children have a normal height, and the short stature is unrelated to kidney function. Here on the right, you can see a presentation published from Georgia, where they could show that with growth hormone, this patient showed some improvement in growth, but he was very stunted. So stunting is a very characteristic phenomenon in Lowe syndrome. Because of the muscle problems, patients have scoliosis. Because of the metabolic disorders, they have osteopenia and rickets, like the patient you've just heard about. And manifestation at later ages, an arthropathy, which can be very painful, which I will demonstrate to you later. Other complications may be a defect in hemostasis, but coagulation tests are typically normal. It's a platelet dysfunction which responds to tranexamic acid. Some dental problems can also arise, enamel, hypoplasia, dentin dysplasia, and eruption cysts. So it is not just oculocerebrorenal, but it is a multi-system disease. Oops, okay, that's bad news, okay. There has been some confusion because some 15 years ago, we discovered that a group of patients having a dense phenotype also had a mutation in OSRL1. It's about 15% of patients who come into clinics with symptoms of dent disease who in fact have a mutation in OSRL1, and the name DENT2 disease was coined for this group. Here you see a patient of mine with Lowe syndrome, and this is another young boy with DENT2 disease. You can see that they are completely different in phenotype, but this boy also has an OSRL1 mutation. The DENT phenotype clinically is mostly restricted to the kidneys with low molecular weight proteinuria as the obligate finding. But if you really search these patients intensively, you can see that they also have some minor Lowe symptoms. About 40% have mild cataracts, which are only visible once you search for them. There is some mental retardation in some of these patients, and they also have or often have an increase in CK and LDH, which I will be coming back to later. You can also see that they are also stunted. They are more stunted than children with DENT1 disease, but they are taller than patients with Lowe disease. As you can see, not all the symptoms of Lowe syndrome are present all the time, but they develop with time. Prenatally, you can already see the cataracts. And if you do an amniotic fluid analysis, you can see that the alpha-fetoprotein is increased. But the cataracts can be seen before birth. And in the neonate, if you look for them, you can find the cataracts, the muscle hypotonia. This is something very specific to the disease with the absence of the tendon reflexes, as we just heard. You can see the elevation of CK and LDH, and the first renal symptom is low molecular weight proteinuria, which is already present in the neonate. At the age of about 1 to 3 months, the symptoms of renal Fanconi syndrome become evident, and in infancy, the eyes get worse with problems of glaucoma. The patients develop the growth retardation we talked about, and it becomes evident that they have a developmental delay. In childhood, the temper tantrums, the behavioral symptoms become evident. The eyes get more problems with corneal scarring, and the kidneys deteriorate, developing interstitial fibrosis and glomerular sclerosis. And because of the muscle weakness, patients get problems with scoliosis, and in adulthood you see a progressive decrease in kidney function and the arthropathy I will be telling you about later. At any age, patients may manifest with seizures, and the platelet dysfunction is also something which is age independent. Well, let's go into the pathophysiology of the disease. And I told you that it's the phosphatidylinositol 5-phosphatase which plays a central role. And to understand this, we have to know that there are a number of phosphoinositides in our body, 7 different types, and they are distinct by their phosphorylation pattern. In fact, the position of phosphorylation in the inositol ring determines compartment identity in a cell. For example, here at the brush border, you see phosphatidyl phosphatase at 1,5 position. But if you look here at the bottom line, you can see that it is phosphorylated in 3 positions. And the endosome here is only phosphorylated in the number 3 position. So the position of the phosphorylation of the molecule determines what time, where the cell sorting takes place. And the OCR1, you can see it here as bottoms, is involved in many processes in the cell. And this explains why the disease is such a multi-system disease, affecting so many different functions in the central nervous system, the eyes, the skeletal system, and the kidney. OCR1 is involved in cell polarity and cilia formation, cell migration, cell adhesion, cell signaling, phagocytosis, remodeling of the actin cytoskeleton, and also, and this is what the nephrologist looks at first, it's the absorption of low molecular weight protein with membrane and endosomal trafficking. The OCR1 molecule gene is quite a large gene with a lot of different exons, and depending on where the mutation is located in the gene, a different phenotype or different functions are affected. And the most important part is that here at the N-terminal and in the first 8 exons, if you have a mutation here, you see in particular problems with endocytosis, and this is the phenotype of DENT2, so the mild phenotype in Lowe syndrome. While if there is a mutation in this part of the gene, then you get the full-blown Lowe syndrome. And why is this? Probably because there is an additional translation initiation codon located here in exon 5-8, which means that if there is a mutation here, there can still be the rest of the molecule can still be produced. Here are the main themes of OCR1 functions: endocytosis here on the left side, but here it's in particular here on the right side, cell migration, cell polarity, ciliogenesis. So very many different processes are involved and are affected by mutations in OCR1. There is, and this is of course where a little bit surprising, there is no strict genotype-phenotype correlation. At least 5 mutations have been reported which manifested both as DENT2 and as Lowe syndrome, even within the same family. This is something we don't understand. If you look at the 5-phosphatase activity in fibroblasts from patients from Lowe syndrome or DENT2 patients, you will see that there is no difference. So this is something we also do not completely understand. Perhaps it is due to modifying genes like INPP5B, which can compensate for the OSRL1 defect. But to be quite honest, we don't know. Well, if we look at female carriers, then you can see that in about 60% Lowe syndrome is transmitted by the mothers, and in general, the mothers are asymptomatic. Only 10 cases have been published in the literature who had a more severe manifestation. But there is one finding which is pathognomonic in female carriers, and these are these punctate lens opacities, which can be found if they are sought for, but they do not give clinical symptoms. So you have to look for them to find them. Now let's go into a little bit more detail into the manifestations of Lowe syndrome. The eyes, well, this is in most patients the first and the eye catcher leading to the diagnosis, because the congenital cataract is often already recognized at birth and requires lens extraction to give some visual development in the first months. A little bit later, patients develop glaucoma, which often needs surgery, and later in the disease, the corneal keloid, the scarring develops. It is important clinically to avoid contact lenses. Patients should not be prescribed contact lenses because they further lead to keloid development. More than 50% of the patients are legally blind. That means that they have a visual acuity of less than 10%. Well, in a patient of parent-reported reasons for blindness, it's the glaucoma which stands in one, and corneal scarring is very important. There is also a retinal defect. I believe this is because of the cilial problems in Lowe syndrome. Anyway, it is a very severe ophthalmological disease. The central nervous system is perhaps the most debilitating part of the disease. Well, it's a muscle hypertonia of a central origin. The absence of tendon reflexes is very pathognomonic for the disease. Most patients have an IQ of 40 to 50 with a delay in motor milestones. Independent ambulation is often only achieved at the age of 6 to 13. About half of the patients have seizures, and there is this peculiar increase of muscle enzymes. It is not a muscle disease, but there is this increase of CK and LDH, which is also almost pathognomonic for the disease. From later childhood, patients develop a very specific behavioral pattern with temper tantrums in response to frustration, stubbornness, irritability, hand flapping, repetitive purposeless movements, aggression, and automutilation. And this, if you compare these symptoms, of the prevalence of these symptoms, to patients with comparable mental retardation or visual impairment, it stands out that this is more frequent in patients with Lowe syndrome than, for example, in children with very poor vision or in patients with Down's disease. This can be very difficult to treat, and some people have used risperidone of paroxetine, clomipramide, but there is no real good pharmacological treatment for these symptoms. Well, we are nephrologists here, so let's look at the renal phenotype of the disease. As I told you, it's an incomplete renal Fanconi syndrome. The low molecular weight proteinuria, which is due to a defective reabsorption of filtered low molecular weight proteins, is present in all patients and can be the first clue to the disease from a nephrological standpoint. Patients have a lot of hypercalciuria. They have nephrocalcinosis in about 50% of the cases, which is less than in DENT1, for example, although the prevalence of hypercalciuria is the same. Aminoaciduria, renal tubular acidosis, phosphate and potassium wasting, all these symptoms are present in the disease and well, give the phenotype of the incomplete renal Fanconi syndrome. Glycosuria, and this is why we say it's an incomplete renal Fanconi syndrome, is rare in Lowe syndrome. Kidney function is decreasing with time, but it is difficult to monitor because the patients have very low muscle mass. Creatinine, if used in the normal setting of a Schwartz equation using a K value of about 38, will miss a lot of loss of kidney function. So you should either use cystatin C for monitoring kidney function or use a K value of about 26 in the Schwartz equation when using creatinine in micromole per liter. This was calibrated by Bökenkamp in the past when he measured chromium EDTA clearance in these patients. The progressive decline of GFR is not related to the presence of nephrocalcinosis. It is tubular interstitial fibrosis and glomerulosclerosis leading to loss of kidney function. So focusing on the nephrocalcinosis will not help preserve kidney function. Most patients reach end-stage kidney disease in adulthood, and there are incidental reports of dialysis and transplantation. Of course, it depends on the degree of retardation of the patients if this treatment is prescribed or not. Well, looking at endocrine function, I told you already that patients are stunted. So the median height is about 150 centimeters in adulthood. It is unrelated to kidney function and it is resistant to correction of the renal tubular dysfunction. Of course, our treatment is aiming to correct the tubular dysfunction, the metabolic consequences of tubular dysfunctions, but this will not correct the thing. About 50% of the patients have undescended testes, and it is also typical that puberty is delayed compared to other children. And a hypothesis brought forward by Senna et al. In 2022 is that this is due to a hypothalamic defect in Lowe syndrome because OSRL1 is highly expressed in the hypothalamus. So this might also be a reason to look into the growth hormone axis, and if you see that there indeed is a defect in growth hormone synthesis, then growth hormone treatment, as we've just seen, might be considered, but it is clearly no standard treatment. Where I talked about the bone problems, the articular problems in Lowe syndrome, because this debilitating deforming arthropathy can be a big problem in older patients with Lowe syndrome. There is, as far as I know, no specific treatment for that. And until recently, we did not really know why this happens. But I came across a paper from 2015 showing that OSRL1 is expressed in the human cartilage. And in patients with osteoarthritis, it is downregulated. And this group could show that by upregulating OSRL1, they could prevent osteoarthritis in an animal model. So, and this appeared to be related to the row gap domain of the gene. So it is, to me, it is quite likely that in fact it is the OSRL1 defect leading to a defect in cartilage metabolism. So what do patients with Lowe syndrome die of? This is not very clear from the literature. Most reviews state that death typically occurs in the 3rd or 4th decade, and well, one would think, okay, this is because that's the age of end-stage renal disease in most patients. Well, Zaniev, he did a literature search for case reports and contacted treating physicians. And well, he collected 15 cases. And in these 15 cases, the median age at death was 7 years, which is much earlier than I would have expected from the literature. And looking at the causes of death, it was pneumonia, respiratory failure, sepsis, seizures, unexplained death in sleep. And so only in 2 patients, death was attributed to end-stage kidney disease. So the kidney is not the driving factor in the mortality in Lowe syndrome, it appears. So to summarize my talk, Lowe syndrome is a severe multi-system disease. In particular, the extrarenal manifestations determine the burden of the disease. Mortality appears to be unrelated to renal failure in most patients. It manifests as an incomplete renal Fanconi syndrome with low molecular weight proteinuria being present in all patients. It leads to slowly progressive loss of kidney function, which should be monitored using cystatin C, or be very aware of the low creatinine values in these patients because of their low muscle mass. I believe that nephrologists are not involved in the care of many Lowe patients, and if we want to learn more about the disease, I think it's important to contact the patients, the parents. For example, in the United States, the Lowe Syndrome Association, and in Britain, the Lowe Trust, to learn more about this disease. Thank you very much for your attention.
Thank you, Tina and Arend, for this very nice overview. And I think also always, let's say, the involvement of ePAGs in these kind of webinars is very important, because we then not only see, let's say, the clinical perspective, but also the perspective from the part of the patient, or as in this case, part of the parents of the patient. So a specific thanks also to Tina, I would say. I am looking at our question box, which is not full yet. So please, if you have any questions, put them in the question box. The first question that I would like to ask you, Arend, is from whether I can see the. No, I can't see the name of the person that is asking the question at this moment. But at least the question is: do you think that the disease manifestations in mothers depend on X inactivation?
Yes, I think this is the case. I think that there is it's the X inactivation which determines why some women have more problems than others. Only the part of the eyes, the cataracts, they are obligate. So this here, the sex inactivation, apparently does not help sufficiently to protect against the cataracts, but they are very mild cataracts. But for all the other things, I think that in general, women are protected by their healthy X chromosome.
Okay. And another question in the question box is whether you recommend treating these patients with ACE inhibition for aminoaciduria, but maybe you can also broaden the question as to what should actually be the treatment, and is there a treatment reducing or at least doing anything on the EGFR slope in these patients?
Mm-hmm. Well, I'm not aware that it is possible to improve or to retard the deterioration of kidney function. In fact, there are no studies evaluating if it's possible to ameliorate the disease by using ACE inhibition. From a theoretical standpoint, I do not believe that ACE inhibition is useful because the proteinuria we are seeing is not albuminuria, it's not glomerular, but it's a tubular proteinuria, so it is unlikely that ACE inhibition helps. Here you also have to be aware that this is a salt-losing nephropathy, and if you give ACE inhibition, if in someone who is a salt loser, you also run the risk of getting pre-renal failure. So the general recommendation is not to use ACE inhibition in these cases. And when we look at patients with dense disease, and if you look into detail of what is the effect of ACE inhibition on proteinuria, you can see that in general, the effects are very disappointing. You do not see a normalization of proteinuria, which of course is not to be expected because it's not a glomerular proteinuria.
In the same context, I saw that you said that glomerular sclerosis is also a feature of Lowe disease. Yeah. Is that then actually a primary glomerular sclerosis or a primary glomerular pattern, or is it secondary to the tubulopathy or the interstitial fibrosis that occurs?
That's it. Yeah. If you do biopsies at different ages, you will see that the first thing you see is the tubular interstitial fibrosis, and the second part is a secondary glomerular sclerosis. So it starts with the interstitial fibrosis, and then you lose the nephrons. So it's this has been shown nicely in the past that if you biopsy at different ages, you will see that it starts with in the beginning you don't see anything, and then it's interstitial fibrosis, then it's glomerular sclerosis, and then the kidney function is lost.
And also in the context of treatment, you said that the loss of kidney function is not related to the nephrosclerosis or to the amount of nephrosclerosis that is present. Does that also hold true for the hypercalciuria? And does that then mean that treating hypercalciuria is also not relevant in this disease? And how would you say is that the case in DENS 2 and in DENS 1 to get the whole spectrum?
Yes. If we are talking then now, okay. No, but they are related, in fact. Well, the point is that the nephrocalcinosis is unrelated to the prognosis of the disease. So nephrocalcinosis should not be our primary goal in treating the patients. The point is that many people prescribe hydrochlorothiazide to try in an attempt to reduce the hypercalciuria, which in fact at short term in dense disease is effective. It does reduce the hypercalciuria, but it has never been shown that it improves the prognosis of the disease. And certainly in a salt and potassium losing nephropathy, you really run the reason of having hypokalemia, which I think it's not a good idea to do that. There are also independent of dense disease, of Lowe syndrome, whether treatment with hydrochlorothiazide is beneficial in hypercalciuria associated stone formers. There has just been a paper in the New England Journal which showed that it did not help at all. So in dense disease, people consider giving patients potassium citrate. That was tested in an animal model where it had a positive effect. I'm not aware of giving this treatment to patients with Lowe syndrome, but of course, if the patient has a metabolic acidosis, it makes sense to give them potassium citrate as treatment of their hypokalemia and their metabolic acidosis. So my primary treatment would be potassium citrate in these patients.
Yeah, and probably that might also do something on the hypercalciuria.
Yes,
which still does not say that it has any effect on kidney function, of course, but still. I'm looking at the question box again. Let me see. There is somebody who's asking whether a growth hormone deficiency has actually been documented, and are there any other hypothalamic or pituitary disorders in these patients?
Well, there are some cases of growth hormone deficiency which were documented, but it's only case reports, and from what I just showed you, it might be worthwhile looking at the growth hormone axis in stunting. But as you can see, both in Tina's son as in the patient in the growth chart I showed you, growth hormone treatment does not normalize growth. It may give some improvement, in particular if there is a growth, if there is a standstill in growth. But I personally believe it should only be used if you have documented that there is a deficiency in growth hormone, and there are reasons to believe that OSRL1 by co-expression in the area where growth hormone releasing hormone is synthesized in the hypothalamus might play a role. There appears to be a hyperprolactinemia in some patients. This is also noted in the paper from Journal of Clinical Genetics I cited, and this may be the reason why these patients may have pubertas tarda. In general, testosterone levels are normal in patients with Lowe syndrome.
And another question in the question box is, and that actually is related to the discussion that we had earlier, whether DEN2 and Lowe are now actually different manifestations or phenotypic variability of one disease, or do you really see these as two different diseases? And do you, I'm now broadening the question a little bit, do you see it as Lowe syndrome and dense disease, which has two different genetic causes?
That's the most difficult question today. Well, we are preparing a guideline together with Francesco Emma on Lowe syndrome, and one of the questions is, what is the relationship between DEN2 and Lowe syndrome? I personally believe that DEN2 is a milder phenotype of Lowe syndrome because they share a lot of similarities, which is mostly focused on the left part of the gene defect. So it's the membrane recycling. DEN2 runs a more progressive course than DEN1, which also is a little bit more like Lowe syndrome. So my personal idea is that DEN2 is a mild form of a milder form of Lowe syndrome. But if you look at the neurology, there is, well, I'm not aware of the seizure problems, and also the eye problems are so much milder in DEN2 than in Lowe. So I think from a nephrological viewpoint, DEN2 is a DEN disease and not a Lowe syndrome. But in looking at the patient, I think it is a mild manifestation of Lowe syndrome. But it's somewhat semantic because, okay, it doesn't make so much difference for the patient. It's the symptoms of the patients which count, and not so much the sticker I put into the file if I call it a DEN2 or if I call it a Lowe syndrome.
Yeah. I think this last
because
comment
this is also
very,
what we heard from Tina's son. In some ways, Tina's son has a very mild manifestation of Lowe syndrome. The ocular symptoms are very mild, and if because what I showed you at the age of three months in the first year, most children need a lens extraction. They have glaucoma surgery, and all these symptoms her son does not have, and this even led to some delay in diagnostics. It was the short stature and the rickets which led to the diagnosis. So here too you could say, is this Lowe syndrome, or is it some kind of very very heavy dense too? No, of course it's the Lowe syndrome.
Mm-hmm. Yeah. What I was wondering, and that's a very non-nephrological question, is what about this platelet dysfunction? Do we have any idea what causes the platelet dysfunction, and is it platelet dysfunction or is it low platelet number, and does that actually have clinical consequences, or is it just let's say one of the extrarenal features that can put you onto the diagnosis?
No, it's very difficult to demonstrate the platelet dysfunction because the standard bleeding tests, they are normal. I would have to look up which test you need to demonstrate it at all. It's not the platelet numbers. It's the primary coagulation which is disturbed, and it may be a problem. I told you that many patients with Lowe syndrome have dental problems, and it may lead to bleeding problems when you're doing dental surgery. And this is why Arend Bökenkamp told me that in these cases, tranexamic acid can be useful to stop the bleeding. But I would have to look up which test you need to demonstrate the bleeding disorder. It's not clinically evident unless you do surgery, and if you do have it, it's tranexamic acid which should be used, but it's not in platelet numbers.
Okay. And I think there is one $1 million question that is still in the question box, and I kept it for last. Is of course on treatment, and the question here is: are there any adenovirus vector gene treatment possibilities, either in the near or more distant future, that could treat or maybe even cure these patients?
Well, I'm not aware of anything in this field. I think it will be very difficult because it is such a multi-system disease, also involving the brains, the eyes, also tissues which are not very easily accessible to gene therapy. So I'm very skeptical that there will be a adenovirus treatment for the disease. No, I do not believe that. No.
I, of course, was hoping that you would have a little bit more.
But there is I'm not aware that there is anything in the pipeline on that, and because it's such a basic problem involving so many different processes, I'm not very optimistic. No. Okay.
Well, I had hoped that we could end on with an optimistic note. But let's end with again thanking you, Arend, and especially thanking Tina for your presentations today and your insights on Lowe syndrome. Importantly, I have to tell everybody that there will be another ERKNet, and I think it's also an ERKNet ESPN seminar on the 5th of December on autosomal dominant polycystic kidney disease in children, which will be given by Jalila Mekali. So I would like to invite everybody to join again in the beginning of December for this next webinar. And I would like to end by thanking all the attendees of today, thanking our speakers again, and hope to see you all at a later webinar. Have a nice afternoon.
All right.
Thank you. Bye.
Bye.
Bye.